Good afternoon, all. So post-lunch, I'm going to talk about diabetic emergencies. Um, Very important. I'm sure you get to treat these patients every now and then. I hope you will be more confident after this lecture. Thanks, Dr. Rajesh and entire BRiCS team for this opportunity. So before the invention of insulin, any type 1 diabetic patient, one single episode of DK was sufficient for him to get killed. With after the invention of insulin and appropriate good critical care, the mortality has now become less than 1%. And that mortality is also mostly seen in elderly patients with some concomitant illnesses. And we also see deaths when they have intercurrent heart diseases or any infection in the older patients and cerebral edema in younger patients. So these are two extremes of the diabetic decompensation. So DKA, I'm sure it is all probably just a revision. The treatment protocol, I just highlight the salient points. So DKA is the triad of uncontrolled hyperglycemia, metabolic acidosis, and ketonemia. Whereas HHS, it is severe dehydration, hyperglycemia, and absent ketone bodies, and severe hyperosmolarity. So DKA do present in type 2 diabetic patients in extreme stressful situations, and the vice versa is also same. And the overlap, DKA and HHS, is mostly seen in around 27% of the admissions. So coming to pathogenesis, DKA, absolute deficiency of insulin, and along with increased counter regulatory hormones, which leads to unregulated ketogenesis and hyperglycemia and dehydration. Whereas in HHS, it is relative deficiency of the insulin, so which leads to, the insulin is just sufficient to prevent ketogenesis, but not helpful for utilization of the glucose. So leads to severe hyperglycemia, hyperosmolarity, and severe dehydration, which develops over a period of time. So diagnosis, I'm sure you are all aware. Just one point to highlight here is wherever facility is available, better to use serum ketones. Now the bedside capillary ketone meters are available. They even give us quantitative assessment of the ketone bodies, which is very important for us to understand when there are limitations of testing ketone bodies with just nitroprusside test. So this is the diagnostic criteria of DKA and HHS. The American Diabetic Association divides DKA into 3 different severities: mild, moderate, and severe. In almost all, the sugar levels should be more than 250 milligram per deciliter. What is differing is the pH, the bicarbonate, and the anion gap in among the DKA. And HHS is different with plasma sugars more than 600. But pH is generally not affected. It is close to more than 7.3. Bicarbonate is more than 18 or 20. Ketone bodies are mostly absent or very small. And osmolality. Osmolality is quite high with, in HHS, unlike DKA. So coming to serum ketones, the normal would be less than 0.6 millimole per liter. So in DKA, you can see that it is 3 to 4, 4 to 8, and more than 8. Whereas in HHS, it should be less than 0.6. So these are the typical deficits you anticipate. These are important for us to understand before we start treating these patients. In DKA, anywhere 6 to 9 liters of fluid deficit will be there, whereas in HHS, it is from 9 to 12 liters. If it is per kg, it is like 100 ml per kg in DKA, whereas in HHS, it is 100 to 200 ml. Rest of the electrolytes we will just see here. So the major cause of water deficit in both DKA and HHS is osmotic diuresis and loss of free water in excess of the electrolytes. Again, sodium, in spite of so much of water loss, sodium will also be low because of several mechanisms. I'm not going to too much of details because the time is limited. Potassium again is lost because of the osmotic diuresis. However, it is elevated initially when you check because of the potassium shift from intracellular environment to the extracellular environment because of the acidosis. And phosphate, significant depletion will be there. When you check, it can be normal, low, or high. However, whether to treat it, we will come in the next slides. Leukocytosis, you do anticipate some amount of leukocytosis, but generally if it is more than 25,000, suggests that you should consider further workup for any infections. This is one more important slide to understand pitfalls of laboratory tests, which we do see and we are not aware what happens. Like false positive lipase essentially happens because of the breakdown of the adipose tissue triglycerides of not much significance. Similarly, elevated pancreatic enzymes, unless you really investigate, it is generally not reliable. Artificial elevation of creatinine when you do calorimetric method of serum creatinine because of the interference of the ketone bodies. And when you check laboratory tests, it is mostly sodium nitroprusside method, which we should be aware that it checks only acetoacetone, not beta-hydroxybutyric acid. So what happens? Beta-hydroxybutyric acid gets converted to acetoacetone, which continues to get excreted in the urine. When you check nitroprusside test, you will be disappointed that ketones are still persisting. So that is not how we should look at. It is better to look at beta-hydroxybutyrate. So we have to, it's not that we have to do it all the time. We can go by other methods, but this is the rough idea. And the drugs with sulfhydryl group, for example, captopril, can interfere with your nitroprusside test and falsely say that there could be ketone bodies. So next, the most important thing is acid-base status in DKA. By default, it is high anion gap metabolic acidosis. It is very important to remember that these patients will have mixed acid-base abnormalities. To begin with, what happens? It is addition of one, keto acid, which leads to high anion gap, for which there is loss of one bicarbonate. So we do this delta gap, the ratio of gap, to assess if there is any overlying additional metabolic acid-base disorder or additional acidosis or alkalosis. So if it is just high anion gap metabolic acidosis, the ratio will be 1. The gap ratio is what I'm talking. As you start treating with normal saline, what happens? There could be hyperchloremia. So this hyperchloremia can lead to reduction in the bicarbonate. So the denominator, the delta bicarbonate is the denominator, that ratio goes up. So the delta ratio, the ratio of gap reduces to less than 1. So whenever you see that the ratio gap is less than 1 in the presence of high anion gap metabolic acidosis, it is understood that there is a new normal anion gap metabolic acidosis because of hyperchloremia. Okay. So similarly, if the patient, the same DKA patient is having severe vomiting, so what is happening? There is loss of hydrogen ion and chloride also. The anion gap remains the same. The delta anion gap remains the same, whereas the reduction in the bicarbonate is less. So the denominator is reduced. So you will get the ratio more than 2. So whenever there is delta gap ratio is close to 2 or more than 2, it is understood that along with high anion gap metabolic acidosis, there is metabolic alkalosis. So these are all very important while you are treating the DKA patient. So coming to the treatment, so again, it is by default not to forget that it is always airway breathing circulation. The important goals of DKA or HHS treatment is to improve the circulatory volume and thereby tissue perfusion, then gradual reduction of the serum glucose, and of course the ketone bodies and electrolyte imbalance, and of course identify the precipitating cause. So this is a flowchart because if I split, the slides will become many more. So I have put captured the same flowchart what is available. So coming to IV fluids. So after the initial assessment, of course, we are all habituated to assess the hydration status. So by default, we understand the fluid deficit is close to 6 liter in DKA and 9 liter in HHS. So the recommended fluid replacement is 15 to 20 ml per kg or close to 1 to 1.5 liter initially in the first hour, the normal saline. Then you keep assessing the volume status. If it is severe hypovolemia if it is with shock, definitely you should continue similar amounts of fluid with a normal saline, which is close to 1 to 1.5 liter. And if it is mild hypovolemia, you again reassess the sodium level, evaluate the corrected sodium level. What is the formula? It is 1.6 millimole for every 100 increase in the blood sugar above 100. So that you check that and then determine the then you see whether there is any cardiogenic shock. These are few important considerations you should always consider. And then if the sodium is high or normal, then you switch over to half normal saline, and the fluid in the next subsequent hours will become anywhere from 4 to 14 or 15 ml per kg per hour. So that comes to around 250 to 500 ml per hour. Again, with the we are all used to more and more hemodynamic assessment. I'm not going to those details. If the serum sodium is low, you continue to administer 0.9% normal saline. When the serum glucose reaches 200 in DKA, you add 5% dextrose along with half normal saline, and target the sodium between 150. Target the IV fluid would be like 150 to 250 ml per hour. Then you check all the electrolytes, important electrolytes, initially hourly, followed by second hourly. So again, these are just a summary of what I said at this point of time. The choice of fluid depends on the hydration status, serum electrolyte, especially the sodium and urine output. The goal of the IV fluid replacement is very important. Whatever fluid you have estimated to be in deficit for that particular patient, half of that should be replaced in the first 8 to 12 hours. That is very important. See, this is where most of the times our patients are under resuscitated, and the entire estimated deficit should be replaced in the next, the total 24 to 36 hours from the time the patient has reached your place. So addition of glucose, the dextrose solutions to the saline solution should start the moment the blood sugar reaches 200 to 250 in DKA. It is 300 to 350 in HHS. And if it is patients with hypertension, aggressive fluid therapy, the choice of fluid, whether it is NS or balanced salt solution, we will see some evidence about that. But whatever studies have been done till now, none of them have shown superiority over the other. So these are few studies just for you to think whether RL or balanced salt solution can be used. This is a small multicenter retrospective analysis of adults. It's a small study where they studied plasma-light versus NS infusion in DKA patients. The metabolic acidosis resolved little faster, but the ICU stay was not affected. Similarly, this is one more parallel double-blind randomized control trial where they compared lactate containing solutions versus normal saline. There they noticed that it delayed the recovery because the lactate was adding to the already existing glucose burden, because that also gets converted to the hepatic gluconeogenesis was the process was burdened with the lactate. So this is a subgroup analysis of cluster randomized trials. Again, I will not go into too much of details, but the essence is the balanced crystalloids may be preferred over normal saline. But to make you understand that this is the subgroup analysis from the SALT, ED and SMART trial. So the study has its own limitations, but the trend showed that the balanced crystalloids were better. This is systematic review and meta-analysis which was published in 2022. But again, there is a lot of limitation here. It was only 3 studies. Two out of the 3 were open label randomized control trials, which again showed that the balanced electrolyte solutions were associated with faster rates of DKA resolution compared to isotonic saline. There are a few more studies. The results are awaited. The BRiCC ED and the PLUS studies are the results regarding the DKA fluid resuscitation in DKA are awaited. Coming to insulin therapy, it is a fixed fixed rate of intravenous insulin infusion that we always considered doing. Initially, we start, I don't touch the subcutaneous route. It is for the mild DKA patients. Only what we are interested is the IV route. It is the regular insulin 0.1 unit per kg as IV bolus, followed by 0.1 unit per kg per hour as IV continuous infusion. And our target is the reduction in the blood sugar by not more than 50 to 70 milligram per deciliter. If it is not coming down, then we can double the IV insulin infusion in the next hour. Again, when the serum glucose reaches 200 milligram per deciliter, you should add dextrose and as well as cut down the insulin infusion by half. If you have started like 0.1 unit per kg, you reduce it by 0.05 or 0.02 to 0.05 unit per kg per hour. And our target should be to blood sugar between 150 to 200 milligram per deciliter until resolution of the DKA. And the frequency, again, you keep checking all the electrolytes, blood urea, nitrogen, and creatinine. After resolution of the DKA, when the patient is able to eat, after the resolution of DKA, if the patient is able to eat, that is the time to convert it to subcutaneous insulin. I'll not go into different regimens. Nowadays, most of the times we tend to manage these patients in the ICU. We used to convert it, but now for the ease of the endocrinologist to take it over, we generally give that privilege to them to convert it. But however, if you are doing it by the bedside, if it is a naive insulin patient, naive diabetic patient, you can consider starting subcutaneous insulin by 0.5 to 0.8 units per kg body weight. Here you calculate the total dose. You can divide, you make it into half. The half dose can be given in the evening as a long-acting insulin like glargine. The rest is divided into 3 doses: pre-breakfast, pre-meal, and pre-lunch and pre-meal. And we have to look for the precipitating causes. This is again the summary of the insulin therapy. In HHS, the insulin infusion rate is much lower. We need not be very aggressive. It can happen slowly. And the moment plasma glucose reaches 200 to 250 in DKA, you are going to add dextrose. In HHS, the moment it reaches 300, you are going to add dextrose and reduce your insulin by half. And again, whether to give bolus insulin dose, there is no study. Few guidelines recommend bolus dose. Few guidelines do not recommend bolus dose. Potassium, if the serum potassium is less than 3.3, you do not administer insulin. Hold insulin, correct potassium, and nowadays we have, we separately correct it, or another way to do is to the IV fluid, whatever is going, you add 20 to 40 milliequivalent of potassium in each fluid. Bicarbonate therapy, less than 6.9 only, you may consider giving bicarbonate. If it is between 6.9 to 7.1, randomized control study has shown that there is no benefit. You can preferably avoid. Phosphate therapy, there will be depletion, but no evidence says that you need to correct it unless there is any intercurrent associated illness where it is affecting the recovery of the patient. So this is treatment of HHS in nutshell. It is more or less the same like what I have told at this point of time. These are again few salient points regarding HHS. There is no role for bicarbonate here. And the main goal here is volume replacement, which is very important. So the resolution, DKA, we consider it is the patient has achieved resolution if the blood glucose is less than 200, serum bicarbonate is more than 15, pH is more than 7.3, anion gap less than 12. Similarly, HHS, the serum osmolality is the target, less than 320. Gradual recovery of the mental alertness is important. If you are monitoring beta hydroxybutyrate, the target is 1 millimole per liter per hour reduction. If it is not happening, you have to consider increasing your insulin infusion. Complication, again, hypoglycemia, hypokalemia, these are all the regular complications we see. During the recovery phase of DKA, as I said, hyperchloremic, normal anion gap metabolic acidosis, please keep this in mind. Cerebral edema, very rare in adults, mostly common in children because of the reason is not very well explained, but probably because of the osmolar shifts. And thrombotic complications, it's very important that thrombotic complications and DIC are, the incidence are much more in the HHS patients. Then one last entity which you might have all seen nowadays, euglycemic decay. There are many causes like pregnancy, starvation, alcoholic, SGLT2 inhibitors. We have seen plenty of such cases. I'm sure you would have seen this, liver disorders. So the diagnosis is metabolic acidosis. The ketone body concentration is high, but sugars are less. That is the diagnosis. The incidence is close to 10%. And you should consider ruling out DKA if any patient on SGLT2 inhibitor presents to you with acidosis. And we have to remember that these patients on SGLT2 inhibitors, they can present with hyperglycemic DKA also. And the treatment is again glucose insulin infusion and wait for the ketone bodies to resolve and stop the offending agent. So take home points, the treatment of DKA and HHS are more or less same, but we have to definitely remember certain important points when to convert the fluid and when to reduce the insulin infusion. Fluid and potassium replacement should always precede insulin infusion. Don't start insulin infusion to begin with. Make sure that the potassium is adequate. If the potassium is less than 3.3, you start insulin infusion, what will happen? Potassium will shift intracellularly and there can be life-threatening arrhythmias. Frequent monitoring is essential. Underlying precipitating events should be identified. Beware of potential lab pitfalls. Monitor resolution of the diabetic crisis and complications. And fixed rate intravenous insulin infusion should be stopped only 30 to 60 minutes after you administer the subcutaneous insulin. And patient should be able to eat when you are converting it to subcutaneous insulin. Thank you.